Thank you all for having me, and thank you for being here today so that I can talk about a topic that I'm very passionate about, as I am also a very competitive trail runner. So when can I run? It's a question that many, if not all of us, have been asked in our clinics by our patients. Now, we might think about the typical track cross-country runner, the recreational half marathon runner, the trail runner, but I'm also talking about the mother, the father, the grandparents who want to be able to run around and play with their kids, or maybe play in a recreational basketball league. But the point is that most of us run in some way or another. You don't have to be a runner to run. Running is a very functional movement in life. So I've come to realize that we're not very good at answering this question, when can I run? Their surgeon told them something different than their chiropractor, than their physical therapist, than their PA. And for those who did get an answer, the majority of their answers were based solely off of time. So my goal for this presentation is to cover the objective measures that we should consider to give more clarity to our patients when answering, when can I run? So let's take a case. This is a 18-year-old female soccer player. She tore her ACL, MCL, medial and lateral meniscus in the high school regional soccer game her senior year. She underwent surgical reconstruction of the ACL with a quadriceps tendon autograft and a meniscus repair. She's committed to play collegiate soccer beginning the following fall season. She says, "My goals are to be prepared for college soccer season, and I'm concerned about losing my cardiovascular fitness and failing my fitness test as a first-year freshman. I want to run as soon as possible. So when can I run?" With ACL injuries, I repetitively find in practice and in the research there to be miscommunication in what we're telling our patients for clearance for running. There was a recent review that said 99% of the studies reported time-based criteria for returning to run with a median of 12 weeks post-op, but only 18% reported using criteria such as strength and performance testing. Without passing these functional tests, these patients are at 4 times increased risk of re-tearing their ACL. And still, only 41% of surgeons are reporting using strength or functional tests to assist their decision-making, despite the fact that running is a functional progression from these early rehab impairments. The fact is, the literature tells us there's much more to the picture than just a time-based criteria in returning our patients to run. So why aren't we implementing them? Across professions, we're well educated on the tissue healing timeline. We're competent in performing a thorough history and subjective exam. So I want to focus on the areas highlighted here in red. So early rehab, clinical criteria, a strength assessment, and a performance assessment. In the early rehab phase, we address the areas necessary to prepare for adequate loading for returning to run. So does our patient have little to no edema, full functional joint range of motion, looking at the knee, hip, and ankle? They should have normalized gait mechanics, be able to walk for 30 minutes without pain, and less than 2 out of 10 pain with their activities of daily living. If your patient does not meet all these criteria, or they have pain with basic strength or sensory motor testing, then they shouldn't be running because they don't have the appropriate load management. If they do have all of these things, then we can further assess their strength and their performance. In our strength assessment, the quadriceps and hamstring muscles are the most commonly measured muscles due to their active role in stabilization of the knee and motor control while running. The gold standard assessment would be using an isokinetic device, but since the majority of our clinics don't have this device, a lot of us will use the isometric device that you can see in the photo there. It's a handheld dynamometer. The test should look both at the involved and the uninvolved limb, which will then give us the limb symmetry index. The literature shows that about 80% is sufficient for running, but we should eventually strive for that 5 to 10% difference. Then with these numbers, we can look at a hamstring to quad ratio. The hamstring should be about 50% of what the quadriceps are at. And then also don't forget about the gastroc, the soleus, glute med, max, hip flexors, the core muscles. Running is a very functional movement. The soleus here is especially important as it contributes about 40 to 50% of that vertical loading force in the landing phase. When the strength assessment shows appropriate limb symmetry, then we next ask, can they load their limb with the proper biomechanics? The quality of movement performance is equally as important as the quantity for these performance-based tests. These are some listed here below that we use in the clinic, but we have to place our patients in functional movements that specifically load the region of injury through ranges that are required for running. For the single leg press, it's recommended that they can perform about 1.5 times their body weight, because a typical runner, when they land, is putting about 2.5 times their body weight. And I especially like the step down test here, as it allows us to look at the quality of movement, looking at a knee versus a hip strategy, showing valgus knee or hip instability, looking at any navicular drop from the ankle. With the heel raise, we'll test both the straight leg and knee bent to bias the gastroc and the soleus muscle. And then with all of these, like with the handheld dynamometer, we can compare the non-operative knee to their operative knee and gain a limb symmetry index, or we can look at how much load that they're moving and compare that to age, gender, sport performance measures. Then next, if their load is appropriate, we need to look at plyometric tolerance. When you break down running, it's really just single leg hopping over and over again. So they have to be able to produce single leg power, land single leg eccentrically, and then reproduce that over and over again. Look at unidirectional versus multidirectional and the terrain that they're going to be returning to. And here also very important to pay attention to the quality of movement, because if they aren't loading symmetrically dispersed throughout their limb, they're going to compensate in other ways and they're going to break down other tissues. Also here looking at hip versus knee strategy, eccentric quadriceps control in their landings, dynamic knee valgus is that knee coming inward, and we're really looking at the entire chain here. I'm going to show a video of the single leg depth drop to jump, and I believe it's going to start as soon as I click the button. So I want you to watch her trunk. You can see she's going to be leaning towards the left, and then you'll see on the first landing her knee is going to come inward. There'll be a little bit of a wobble, and then on her second landing it's a little bit more stiff. So watch quick here. Maybe. Go. There we go. Okay, so her trunk is already leaning left. Her knee comes in there. You can see that wobble comes up. When she lands very stiff. And then her trunk also leans forward, which shows more of a hip strategy versus a knee strategy. So I compared that to her non-operative side, which had a lot better mechanics, faster ground reaction time, and a higher jump height. Go. And this one here, this guy's running on the treadmill. His operated side is his right knee, and I want you to look at how stiff he is loading through that stance phase. You can see poor eccentric quad control, and that hip is taking most of the load there. Now, when we clear our patients to run, that doesn't mean that it's a free-for-all. It's our job to give them the appropriate guidance. So I typically start with a run-walk program, and then I'll progress into a run program. I'll prescribe volume before intensity or speed, flat before hills, even terrain before any variable terrain, and no more than 10% increase in volume per week. So when that soccer player or that trail runner, the grandmother, the mom, the dad, they come into your clinic and they sit there and they say, so when can I run? You need to ask yourself, have I appropriately isolated the dysfunctional tissue? So for our soccer girl, it's the knee, the ACL. Did I integrate the problem into a larger movement pattern? So that's the hopping, the squatting, the plyometrics. Did we strive towards symmetry, comparing limb to limb? Did I make a meaningful plan, and did I prioritize the patient's goal? And really, did you use your clinical reasoning? And I really like this quote, everyone runs their own race. Return to run decision-making should be very individualized for each patient. There's no universal timeline for returning to run. For many of the ACL patients, it might be reasonable to expect around that 12-week post-op. but that is provided that they meet all of the objective criteria and that you've completed a thorough history in regards to their running history so that you know how to appropriately progress them. Thank you, and if you guys have any questions or want to just talk running with me after, I'll talk about it all day.